Childhood cancers are one of the leading causes of death among children under 18 years. The World Health Organization (WHO) projects that the likelihood of surviving treatment is dependent on the country in which the child lives. In high-income countries, more than 80% of children with cancer are cured, but in many lower middle-income countries, only 15 to 45% are cured. In Ghana, an estimated number of 1,000 to 1,200 cases are expected to be recorded in a year, but only 350 to 400 are reported in some health facilities. Dr. Lilitego is a pediatric oncology fellow at the Child Health Unit of the Kolebu Teaching Hospital. She noted that the facility records about 200 to 230 childhood cancer cases in a year. She adds that the late detection of cases has been a major challenge in childhood cancer treatment.
Globally, over 75 to 80% of childhood cancers can be cured actually if they are detected early. Now, the problem we have in our setting is that the majority of our patients come very late when the disease is well advanced and has spread all over the body.
A pediatric oncology nurse at the unit, Enyo Asibusumpra, is concerned about their inability to save patients who report late to the facility.
When I know that this child I'm taking care of is not going to be able to make it, and there has been occasions when even the children themselves know that things are not going right, and they'll ask you, "Auntie Ness, am I dying or am I going to die?" Sometimes you have to just go somewhere and shed tears and come back to take care of them. Or you know that this kind of cancer, not because the parents don't have money, but cannot be cured well. We cannot really cure the child. But the moment the diagnosis is mentioned, then it's like my heart. As if it's my personal thing, I know that we are not going to do well with this one. Then those who come in already late, there's nothing you can do. So we all know that this is it. And then when you have to break the news, sometimes you have to just keep your hand around parents to hold them to be able to brace up with the pain that they will be going through for the period that the child is going to live.
Failure to detect early cancer symptoms, we are told, is largely the cause of patients reporting late to the facility. Another factor is self-medication until the situation gets out of hand. To this effect, the Child Health Unit, together with the Ghana Health Service and the Ministry of Health, in collaboration with other stakeholders, have instituted some awareness creation measures for the public as well as early detection signs for health workers to enable them identify cancer conditions early when presented to the facility.
What we do with the training is we initially have representatives from all the regions come in and they get trained. Then we facilitate a trainer of trainers session for them. Then from there they go to their various regions and districts and then they have training. So now these people we have trained become the trainers and then they now train the people in their regions and districts. This training that we've done is going to translate into us getting the cases. Like once the parents do present to these facilities, then they are aware that childhood cancer is something that should be at the back of their mind. So it's a hand in hand. So whilst we are still going with the media engagements and posters and stuff, so the parents know, we're also training the healthcare workers so that they also know and then together we can get a representation.
Presently, the high cost of childhood cancer treatment in Ghana is still a major challenge.
So childhood cancer treatment is very expensive, extremely expensive, and for the average Ghanaian, it's really out of their ability to pay. For now, we find most of the patients can't support their own treatment. The majority, 99% really. So for now, the only reason we are able to survive as a unit is through philanthropic donations. We have NGOs that support us, we have churches that support us, we have individuals who working out today's my birthday, get this money, and stuff like that. That's the only reason most of our patients have been able to finish the treatment. But for some of them, they drop off because, we are giving her money for treatment, but she says, I don't have transport. Or even if you are giving her money for transport, because she has to come here, maybe her other children can go to school. So the burden is really more than just the treatment cost. It's a burden. So we've had people who stop treatment because of that.
If the parents come in and because of funds, we are not able to help the child, that is the most distressing moment for me as a nurse, because if they had not come in early, we would blame them for not coming. But now they have been able to come in early, I expect that there should be funds for them to get their treatment on time and then get cured, because we know that the earlier the better. So that has been my most distressing moment, when parents come in and they don't have money to do anything and they have to depend on funds, and then funds are not forthcoming, probably because the philanthropists have not brought some money, or the people who support us have also run out of funds.
Some parents of childhood cancer survivors shared their experiences on the treatment journey with the Ghana News Agency.
The cause is not easy. We are just praying that we need more sponsors. We need more sponsors. For only scan alone, you can go for scan, they say 3,000, 2,500 for only scan alone. Aside that, you need to run a lot of tests before you are able to receive your chemotherapy, because it was not easy. But we thank God that God removed someone special for us, and the person was able to sponsor our treatment. And so far, Lifeline too, they also did a lot. They sponsor us, and other churches they come to sponsor. And sometimes for us to give, it's even difficult. Where to even labor is even price. I'm telling you, yesterday people came, they had to go and sleep outside because of no bed to sleep, and all the floor was even full. And sometimes when I want to even eat, it's problem. It goes to sometimes I nearly ran out because I dressed to move, and it was one body. It was only one woman who saw me and asked me, why are you going by this time? I said, where has you come to one time? There's no help, no one is calling me, no one is sponsoring me. Then I need to go. I wanted to leave the world because I was tired.
And then I was able to marry cancer of the blood. When I'm actually papa, I'm a discuss. Okay, I treat she cancer. That be 100% there, 80 million survival. Okay, you will then when you treat the them as it is right there. And then make a bad job. She can't do problem. You can't do the franchise. I feel to be the franchise. But local crowd, a true local crowd. I know you. Ona, she felt to me tuning few. No me only be uncle. No like I knew where I need be any uncle to check out because Jana me say better from beginning when you want to check it, papa. Or Kawashika. To 1 year, getting to 2 years, 1 year and a half. The one in Kawanas could be even the way you look at me. They were with 4,000. Okay, channel get treated with the few.
Aside the treatment, like when we are doing treatment, some of our parents, the children don't really probably ill before coming, or maybe during treatment their immunity goes down and we have to really support them. So they need to really keep the children clean. They need to wash themselves, the children. They need to keep hygiene issues on top, because we don't want these children to get infections. So these are the issues. If the child, you go home, the child is not feeling well, quickly you have to come back to the hospital. Always we want them to be talking to us about the children, not us to relax and say, oh, I'm coming back in 3 weeks and then relax. No, the moment you see something that is not going right, you quickly have to come back. We want them to feed the children well, because when they are feeding well, their blood or HB, we call the HB, and other blood levels that we want to be good before they get treatment are good. Then we will do treatment accordingly. But when they come in and the children are anemic, we cannot do treatment, and that delays treatment. So we want them to feed the children well. We want them to be neat about taking care of the children.
Despite the challenges, there are some success stories to tell.
Yay, the exciting moments. We should have gone to the daycare to see them. Those who are doing well on treatment, those who have been cured, just coming for review. I see them and I am like, sometimes I even have a picture of one I saw recently that's a teenager. I saw around 5 years, now a teenager. We have people who are working, even some in Kolebu here, who have been our patients. I see them and I'm so excited. I had an opportunity to attend one of them, the wedding of one of our survivors, and it was in who I still followed, because I was just not like anybody forced me, but I felt that, I'm so happy for the boy that I needed to just be there to see the wedding.
In November last year, the First Lady, Rebecca Akufo-Addo, announced the inclusion of 4 childhood cancers on the National Health Insurance Scheme.
Distinguished ladies and gentlemen, I am extremely excited to announce that the NHIS benefit package now includes 4 childhood cancers, namely Burkitt's lymphoma, acute lymphoblastic leukemia, Wilms tumor, and retinoblastoma.
These 4 constitute approximately 60% of all childhood cancers and are highly curable if detected early. She described the inclusion as a major intervention in the fight.
During the commissioning of the Sunshine House, speaker after speaker called for the inclusion of childhood cancers to the NHIS benefit package. Today brings hope to our children and their families.
The Chief Executive Officer of the National Health Insurance Authority, Dr. Lydia Barbajani Selby, says the authority would soon finalize processes to include the 4 diseases on the scheme.
I think we're really proud to be able to add these 4 commonest childhood cancers. The process, we actually did some work behind the scenes to make sure NHIS could afford it, and we can. So now, what we're doing is trying to standardize the guidelines for how to diagnose and how to treat, so that all the cancer experts in the country, that's pediatric oncologists, they are sitting down and actually documenting how you diagnose and how you treat, so that we do the same thing across the country. Then we also have to agree which centers have the specialists, the experts to treat these children, because we want them to be treated well so that they survive. So we are almost done with all of that. We've already done the coding, we've done the costing. So the hospitals will know soon that they can treat and will pay the bills. We are actually ready. I think if any child is referred now, they will not be turned away. If any child is referred now, they should. It's not they will not, they should not be turned away. We're in discussions. So to be honest, we're ready. But we have to still do sensitization, because a lot of these children, some of the factors that lead to it is poverty, malnutrition. So some of these children are in the rural areas. So we have to sensitize the whole country and the CHIPS compound nurses and things to look out, so that when they see it early, straight, they refer to the centers and we can start the treatment early.
She adds that the NHIS will cover full cost of entire treatment.
Treatment that is internationally accepted treatment. We're not doing some of the very latest fancy things, but what is internationally and nationally accepted treatment that we have all agreed, we'll pay for it, and the lab tests will pay for it. Admission will pay for it. Once we accept to pay for something, we will pay until we don't, until we are done. If you are diabetic, we can't say we'll pay for 5 years. We have to pay for 30 years or for however long you are alive. For the chronic diseases, it doesn't stop. The thing about these childhood cancers, though, is about 80% are curable. So we should be able to cure them. The treatment, 6, 9, 12 months. But then they have to be followed for about 5 years to say for sure that you are cured. After that, we're done.
This comes as a relief for both patients and health workers after several appeals to government to reduce the cost of treatment.
It will really go a long way to reduce the burden, because for now, it's not on the NHIS. Everything has to be gone out of pockets. Everything from labs to scans to biopsy to the treatment itself, and it is really expensive. So, for example, for the leukemias, acute lymphoblastic leukemia, which is a common leukemia, and it's part of the cancer that's going to be covered. It's treated for boys over a period of 3 years, and over this 3-year period, they end up spending about 35 to 40,000 Ghana cedis, and you can bear with me that how many people can afford that. So that would really ease the burden.
The day I saw it, it was like I won some lottery. I was so happy because if we are even able to get the investigations on insurance and the parents are not paying for it upfront, it will be a very big relief to us and to the parents as well. So I think it's a very welcome news, and we are very happy to hear that we are so anxiously waiting for the time in the implementation starts.
The Childhood Cancer Hostel, which was constructed by the Ghana Childhood Cancer Parents Association with support from the First Lady, is now operational. The well-furnished hostel facility houses mothers of patients who come from afar to receive treatment.
Most of our parents are not coming from Accra. They come from far, and some even come pregnant or they are carrying another baby, and so they actually need a place. And looking at the period of treatment, it's not only like malaria you are treating for 3 days, some stay even a year and on. So the hostel has come in handy to help us. Even though we're getting some rooms at the mother's hostel that Kolebu has given, it's not really enough. And so you see a lot of people sleeping on mattresses in between the beds that they're given. So having our own hostel is a very big relief for us. And I am happy that the parents, at least where they will lay their head, will be comfortable.
Talking about the hostel, let me use this opportunity to appeal. We need a bus. So if someone can give us or help us get a bus so we can transport the patients to and from the units, that would be great.
According to Dr. Tego, the childhood cancer daycare at the Kolebu Teaching Hospital needs to be expanded to contain the increasing number of cases.
We've had challenges with space. Our unit is currently being renovated by some other body. We thank them as well. But as we go on doing the advocacy and more patients keep on coming in, then we have a lot of space constraints. So again, there are plans to expand and build a unit for us, which again, we need more people to come and help fund that as well, because we want the patients to come in. All these 1,000 patients I said we are expecting, if they all come, honestly, we will know where to put them.
Treatment of childhood cancers places a heavy toll on patients. It is sad to see children deteriorate with little hope available. As advocacy with regard to early symptoms and detection increases, more attention is needed to solve the many challenges associated with treatment. For Ghana News Agency, I am Munira Tuakwele Issa.